Okay, so we might as well start. So hello everyone and welcome to this probably first time we've done a really massive meeting like this. And the reason why we've done it this way, I'll explain in a minute. So welcome to the first BBG LSL meeting on GP-CPCS webinar. I'll get my tongue around that. It's been a long time coming. And much of the sort of slide deck that you're still going to see before you has been done by Pharmacy London. So it's a collaborative effort that we've actually producing so that we have the same consistent approach across London. And that's one of the goals that we have. So today, the meeting is being recorded. I am going to try to upload it onto a YouTube channel. I'll have to make one first, so that's available for everybody to view, because it's one of these things that we have to do. Contractors have to be able to have a meeting which allows them to claim the £300. And I know I had quite a few queries regarding the RPS meeting on GP-CPCS, and this is not clinical. Okay, it'd be very good if everybody can put themselves on mute. I know most of us are at home except for Piyush, our Vice Chair at BBG. Obviously, you may have things happening at home, and it's quite okay to sort of disappear and sort those things out if you need to. So, as I said, this is being recorded. Belinda, who is the Community Pharmacy PCN lead for both LPCs, is going to be managing the chat. So please have a conversation going on in the chat, and if you want to have questions asked or discussions, then please put them down there and we'll endeavour to sort of answer them as we go along. Okay, so what's the aim of the meeting today? So I'm just going to give you an overview of what GP-CPCS is and is not, what you have to do as contractors and as pharmacists to be actually able to participate in it. Why bother in the first place? I know some of the NHS 111 CP-CPS isn't great, but why bother with it in the first place? But it is important that you do it. I think when we talk about the numbers, it will become kind of significant why we should be doing it. What is the LPC doing? Give you like some background information on what the LPC is doing. And most importantly, or as the last point there, is about making sure that you're able to claim your £300. And that £300 is important. I know it may not seem a lot, but for all the contractors in BBG, it works out to about over £100,000. So, you know, we want that money in community pharmacy. So let's start with what GP-CPCS is. It is not a minor illness service. We don't even use the word minor illness, minor ailments anymore. We tend to go with things like low acuity conditions. And I think if many of you start talking that similar type of language about low acuity, that's why we want to be talking about it. The vast majority of you already probably participate in the NHS 111 service, and it's very, very similar to that. Okay, the only difference is that the referral is coming from your GP. It's not coming from NHS 111, but it's coming from your GP. And we're quite fortunate with NHS 111 referrals. You'll tend to find that South East London has the most out of London, and that's partly due to NHS 111 ambulance service, which actually manages the referral service. They're quite, they have confidence in community pharmacists being able to handle those services. So what happens to the consultation when you have it, when the patient comes in? There's three outcomes that happens. One, that you'll give them advice. Two, you'll give them advice and an OTC medicine, or you will refer them onwards. You'll tend to find that I use word refer as opposed to signpost all the time, and that's important for you to understand. My apologies, but I keep having to admit people in. So I was just looking at the NHS figures earlier on, which are not good for London. London is second from bottom at the moment with about 200 referrals, and nationally there are just over 10,000 referrals, and we're aiming to make sure that we get more. So I was just doing some back of the envelope calculations. There's 220 GPs, and I was in a meeting with a clinical director today, this morning, and he was saying it would be quite easy for him to refer 10 patients per day to community pharmacies around his surgery. So if he can refer 10, if you sort of extrapolate, that's like 2,200 referrals per day in Southeast London, which is about 30,000, and it works out about 11,000 per week. So you're looking at big numbers. And over the years, I've sort of calculated it's around about £8 million worth of fees coming into community pharmacy. So that's why the focus of the LPC is on this particular service to land it, because it's a considerable amount of income that's just sitting there waiting for us to sort of get our hands on it. Otherwise, what happens is it goes back into the global sum, and then it's sort of divvied up to all the contractors based on your prescription volumes. And as we all know, our prescription volumes in London are lower than nationally, so we kind of miss that. So what happens to the referrals that we get? So I'm looking at the NHS Services website this morning. 35% of referrals are dealt with by community pharmacy with the device only. 23 is a device in a cell. 13 is where they're referred to another PGD service. So it's quite, so if you've got any private PGDs within your pharmacy, it's quite good to make sure that you keep up to date with them. And of those, 60% require a non-urgent GP appointment, and only 8% of those referrals require an urgent GP referral, and about 5% require onward referral, that may be to A&E or other places. Yeah. So, you know, the numbers, we need to make sure that we land this service to actually allow us to generate income for our community pharmacy colleagues. So what is the LPC doing? The LPC has been working, and when I say LPC, I mean both LPCs. I'm just going to use the word LPC, and it implies to both BBG and LSL. So we've been engaging with commissioners at all levels across Southeast London. You know, starting right at the bottom at neighbourhood, place, system, and then right up to regionally. I've even had a chat with NHS England London region, NHS England Central team on Friday, pointing out our frustrations at the barriers that have been put up to the service and the way the service has been designed, implemented, and actually landed for us to take it forward. So we are working extremely hard across the commissioning side, and we're also working hard within the LPCs. As I said, we worked incredibly hard to create some very detailed documents. We've produced a Gantt chart which we give to the GPs to allow them to plan. I've also shared that with the CCG. I've shared a draft of the form that they can use as well. So there's a considerable amount of work that we have done that will allow us a smooth roll up. But we also need your help. We need to make this work together. So when you approach your GPs or practice pharmacists or the practice managers, you need to be in a position where you're able to sort of talk about GP-CPCS in terms of how it helps the system. Well, what do we mean by that? It means that we're able to save about 6% of the GP appointments, which is really the way we need to be improving that, because as we emerge out of the pandemic, it is going to need all of us to ensure that we're able to treat our patients at the right place, and that's not necessarily the general practice. So it does need all of us to be working together, and what we already want to do is to make sure that it becomes almost routine for this referral to occur into community pharmacy, and it requires you to look at how you work within your pharmacy. So what's your capacity to be able to do with these consultations on a daily basis? Are you able to manage 2, 3, 4, 5? How many are you able to manage in your community pharmacy with your current workload? And that's how you've got to view this, because it will, I feel it will start off slowly, but as it gains momentum and as GPs find that they're able to what we call channel shift patients from their surgeries onto community pharmacy, they will do so. And the strategy behind that is also to make sure that if we succeed in that, then I'm sure there will be other services coming our way on the back of GP-CPCS. However, it's not always smooth sailing. We do still have some barriers that we come up with. It is a service that is dependent on an external healthcare professional actually referring to you, and there can be sort of some blocks there along the way. You know, we do want to see a uniform process of referral. So I know we're dealing with NHS email at the moment with shared emails, and I'm sure you've seen the surveys that have been sent out by the LPCs to say, are you using your NHS shared email? We've had a fantastic response to that. I mean, I've had over 100 contractors respond to that in both LPCs, in each LPC, so it's over 200 across cell. There are 1 or 2 that I see are still using their legacy NHS emails or their personal NHS emails. So I think really those need to be sorted out. You need to be using your NHS shared email address, please. And if you don't know how to get hold of that, I did send out a link which was really very kindly produced by Atul Patel from St. George's Pharmacy. He's done a couple of YouTube videos for you to see how to set up a NHS shared email. So we're all here trying to see how we can overcome the barriers. Some of the GPs are saying, oh, we want to only work with a few pharmacists, not all of them, and that's totally unacceptable. We will not endorse that viewpoint. We absolutely need to make sure it's available to every single community pharmacy, and therefore a patient has choice to go to their pharmacy. They are saying the workload for their receptionist staff, but I'm not really sure to that. The other one is talking about whether they are going to be liable for when they actually patient or signpost the patient. So do you mind if we mute, please?
Raj, you might have to mute everybody.
So it really does depend on how we actually embed this service in there. I am making representations to the South East London CCG to see if they can invest in one form of the digital solution, so that we've got one solution across all of London and not so many. So that way, I know most people are work in one borough and live in another one, so it's, I mean, I do that, so it needs to be a uniform solution. I mean, the nightmare scenario will be if we have all sorts of different solutions going everywhere, from Pharma Outcomes, AccuRx, Ardent, NHS Email. It will be a nightmare. It will be too much to understand which system is used by which pharmacy. It would cause massive problems, and that message has been relayed to the central team at NHS England for myself personally. Okay, some of the other key issues about liability. Who has the liability when making referrals? They're talking about how easy, we need to make it easy for both. We need to make it easy for the surgery teams as well as the teams within the pharmacy. It needs to be easy for everyone. Okay. 1 or 2 GPs have brought out, well, is it a loss of income to their surgery because they're referring patients out of their surgery? Well, not really, because they won't be prescribing for them anyway. They're not looking after them. In a way, we are providing a service to them which alleviates the pressures that they have anyway. So there's no loss of income to them. Yeah, and so some GPs are saying, why can't my staff just tell them to go to the pharmacy? Well, that's signposting and not a referral. When a referral is made, it is a case of that sort of the GPs actually transferring the clinical responsibility over to you. And don't be scared by that. You do it every day. You know, every time you dispense a prescription, you're taking over clinical responsibility. Every time you do a normal CP-CPCS, you're taking over clinical responsibility. And I want you to get used to that. You should get used to the fact that you want to take over the clinical responsibility of a patient. You're able to have a consultation with them. You're able to provide solutions for them. You're able to provide a care plan for them to make sure that, you know, at the end of the day, that patient is looked after within your community pharmacy. And once you're able to do that, you'll see that other services will be bolted on to this particular service. So, you know, I also sort of mentioned to NHS England and I that maybe within the e-consult of the GP surgeries, there can be an element where patients are able to click a button and refer using the GP online consult to community pharmacy. So they actually, the triage doesn't happen in the surgery, not all by the staff. It actually happens within the e-consult. But what I do need to make sure is that everybody is aware that they are making sure that they are actually seeing red flags and are able to recognize and also able to refer patients on as well. Sorry, I'm just trying to let some people in. And that's just like a summary of the common barriers that we have come across. And those barriers will be overcome by training. So it is a case of, it's something new. And I'm going to be honest with you, NHS England hasn't actually raised awareness of this in general practice. So it's kind of been left to the LPCs to do the groundwork. So we've been doing this for the last few months with up-team meetings with clinical directors, with practice managers, with the NHS London region team to make sure that that level of awareness is raised and people are actually engaging and able to understand what it means to be actually participating in this particular service. Right, so what have we done as the LPC? As I said earlier, we've produced an in-depth and very detailed documentation for contractors and pharmacists and also for GPs. I will be sharing those documents with you after this meeting because they're quite detailed and I didn't want to send them out without actually having to explain to them what they do. So there's all sorts of things in there. It's checklists, it's standard operational procedures, it's actually flow diagrams, what to do and answering, you know, frequently asked questions and all those kind of things are there for you. So this particular webinar that we're holding at the moment is purely fundamentally to make sure that you're able to claim your £300 setup fee. The reason being within, as I go show you in slides later, it requires a system leader to deliver the webinar so that you can actually tick a box so that you can say that, yes, I've attended a webinar, we've had a discussion, I understand what GP-CPCS is, I understand what I have to do to help promote this within my PCN. And prior to this meeting, we've also had a meeting with the community pharmacy PCN leads. They've also been made aware of what the documents are and how to use them and how to sort of go out and engage with their PCNs. We've also got Belinda, who is, as I said, our support and facilitator for PCN leads, who's helping out today as well. So it is absolutely important that we actually make sure that we're working and have a consistent common message that's going on. Now, step 4 is the mobilisation and rollout. So today's meeting I had with a PCN lead in Lambeth, who was very keen to roll it out because he can see that it's going to save his surgery a lot of time having to deal with these patients with low acuity. So we've already set the plan in place, and we should be going live in Lambeth in about 4 weeks. I know it sounds a long time away, but it's only a short time. And he has also he's going to also be my champion within GP land. So he said he will be able to advocate on our behalf at PCN meetings in South East London and also within Lambeth and other boroughs. So it's very important that we actually, once we've got the service in place, that our contractors around that GP know what to do and respond. And more importantly, one of the things that he said to me was very important was the feedback. So they want to know what exactly has happened to their patients and within a reasonable time span. So within 24 hours, I mean, you need to be, if you get a referral, you need to be anyway, turning it around within 24 hours. So that's the brief, make sure that you're able to turn that around in about 24 hours. Okay, so oops, sorry. So, as I said earlier, this has been a team effort, and Pharmacy London strategy. We developed the strategy sort of late last year to look at how we were going to roll this out. So, we've all LPCs in the Pharmacy London have collectively come together and built a strategy, written the documents, and then we'll go out to our individual LPCs, and then the LPCs go out to the individual PCN leads and individual GPs and community pharmacies. So it's a cascade of information down, and then feedback cascades up, and we improve it and we cascade it down again. So we're in the beginning of that process where we actually are working at individual LPCs level now, engaging with clinical directors, engaging with pharmacy teams, engaging with surgeries to help unlock GP-CPCS for our contractors, because I think it's really, really important. Okay, so this kind of sums up where we want to be and the kind of actions that we want to take. The champions, we're calling them champions, but they are our PCN leads. Both LPCs have committed funding to help the PCN leads with their extra workload. So it's not a case of they won't be sort of recognised. We will make sure that the GP-CPCS champions are properly looked after, and especially because this empowers the whole network to engage with general practice, and it also sends a message to the system saying, you know what, we're able to look after patients, we're able to look after them clinically, and that's an important message that I think we need to send to the system. What I mean by the system is the ICS, so South East London ICS is a system. So we really want to be sort of engaging with them at a system level, at a PCN level, at a local level. So we're doing our bit at the system level. So I really want everybody else now to be doing their bit at a local level after today. So there are various IT solutions out there, and we've kind of summarized them for you there at the moment. Sorry, my apologies, my mouse is playing up. Probably the best one at the moment, and it costs, there is a price for that, is patient access, which most surgeries within London will be going over to EMIS. And EMIS, as many of you probably know now, own Pharma Outcomes. So the EMIS package is, there's a little button on the surgery, PMR. So when a receptionist or a healthcare professional is triaging that patient, they can press that button and it automatically sends an email to the Pharma Outcomes in your pharmacy, and then you're able to deal with that. We've also have Sonar. I'm still waiting to view what he's able to do. I'm still waiting to see what he's able to do with the link from the surgery to the pharmacy. I mean, we know what he's able to do because we use that for NHS 111 GP-CPCS. So, I mean, with that part of the platform is well known. It's the part from the surgery to the pharmacy that I don't know. And there's other things called Farm Refer, and obviously NHS Email is probably one of the easiest ones we can use. And then we have things like Ardents and AccuRx and eConsults, which have templates built into the GP surgery PMR, which are automatically populated and sent to community pharmacies. The only problem with those is that community pharmacists then have to upload them or into their own records. So sort of from sort of a pharma refer downwards, you'd have to be in a position to how you would make a record of this on your PMR, how, you know, whereas with Patient Access and Sonar, that's done for you on their platform. And as I was saying earlier, I am working with South East London CCG to see if we can get them to fund Patient Access or another IT platform, just to ensure that we have a consistent way of delivering GP-CPCS across South East London. And if we get that, once that's embedded, you'll find that the service will take off because it becomes easier for everybody to use, mainly, more than anything else. This is a rather complicated slide, and it just kind of lists there what we need to do from an LPC point of view and from a contractor point of view. Most of it is green, as you can see. There's the amber bit is engaging with the CCGs, GPs, PCNs. That's been done. It's now that turning that engagement into making sure that GP-CPCS is actually delivered. Okay, so this is the bit that you've all been waiting for, how to claim the £300. In the specification there in Appendix F, there's very specific sort of notes that have to be, the contractors have to go through in order to claim this. I am aware, in London at least, there are a few contractors that have already claimed this money without actually having done any of the attending of the seminars or anything like that. So, but if you attend one of these seminars and you've been through the discussion phase, you will be able to claim that money. Okay, so the first requirement is for a discussion where it's been provided by a CCG or NHS England lead project or the LPCs. We're sort of called system leaders, so they need something specifically to be delivered by a system leader so that you're able to claim that £300 engagement free. You know, the contractor must participate in discussions with the LPC to explore how they can take and promote GP-CPCS locally, and this is what this event is all about. Okay, I'm quite happy to hold more local ones. I've just requested North Lambeth PCN community pharmacists to come together because that's where we want to be rolling it out to that particular service. So that ticks that box off. Again, when you're in a meeting, obviously web-based at the moment, to discuss how to interact with potential pharmacies, and the training element is obviously virtual outcomes. I don't really want to go and show you the 20-minute virtual outcomes training module, but I do implore everybody to have a look at it, and I definitely implore everybody to make sure that their frontline staff, I mean the counter staff, actually view it and go through it. I helped the Saturday staff where I locum. We did it at 5:30 at the end of the day, and they kind of whizzed through it. So I would highly recommend that you get your teams to go into virtual outcomes. We have commissioned virtual outcomes. The LPCs have commissioned virtual outcomes in combination with Pharmacy London. So it is a very good deal. So please, please, please make use of that. We are also giving the link to GP surgeries for that element of the training. So their staff are using the same training that your staff are using. So we have a consistent approach between both professions. So it's very important that if I'm pushing for my surgery, my colleagues in GP land to use the training, then I'll equally want pharmacy colleagues to be using the training as well. Okay, so if unfortunately some contractors are not able to make it, because unfortunately today I'm aware that there is a COVID webinar going on simultaneously. So this meeting, as I said earlier, will be recorded. I'm going to work out how to put it up on your YouTube channel, and that will be available as a sort of online resource. But depending on the feedback from you guys and people that obviously view the seminar, then I'm more than happy to hold like a mopping up event thereafter to make sure that everybody is able to sort of understand the concept of GP-CPCS. Okay, so as I mentioned earlier, I will be sending out the tool pack. It is a hefty document. So what I would suggest you do is read it a bit at a time, but it has everything that you will need to have your pharmacy ready to engage with GP-CPCS.
So, because they might say,
so I just want to make sure that the training is in place for everybody. I want to make sure that you're all ready to be able to deliver that and all ready to claim your £300 fee. And within the Annex 5, there's specific sort of criteria that you have to do. The action plan we've done for you. We've made sure that your staff are able to update themselves on GP-CPCS through the documents and also through the webinars and also through virtual outcomes. So there's a whole host of structured training that is, there is a whole set of structured training that's available for you to ensure that you're able to deliver GP-CPCS. Okay, I don't know if any of you have been on virtual outcomes, but if you go into virtual outcomes, all you need is your ODS code and you'll be able to access the training. So it kind of looks like this. So this is a GP-CPCS model, which you click on. What it requires you to is to fill out your details and you're able to then view the module and answer a quick sort of assessment thereafter. And staff are then able to get themselves a certificate, which you can use as evidence that your team is ready to deliver GP-CPCS. All of the other ones are very good to have. I suggest you have a look at them. It's good to use them, but you don't have to. But you know, it's a good resource for you to keep your staff trained, and also it provides an evidence base if you do have NHS England visits or GP-CPCS visits. Okay, so this particular one, the GP training one, is the same module as the pharmacy one, but this is the link that we share with GPs. So this link has been shared with the CCG and they've shared it out with all the surgeries, so they're able to actually view that training. So it's a good idea because we've sent that out to GPs. I would strongly recommend that your teams also undertake the viewing of that module. Okay, and finally, I just want to say a big thank you to the community pharmacy PCN leads, and also to Belinda, who actually is supporting and facilitating them. They have done an incredible job in making sure that you were able to get your pharmacy quality scheme payments and fulfill the criteria. It can be scary, but you know, I think being a PCN lead is an opportunity for everyone. And what I'd like to see is to develop that as a career pathway for community pharmacists, to be able to engage in the wider primary care sort of architecture, and sort of perhaps even move into the LPC even further. And engage at a level to ensure that we maintain the health of community pharmacy. Now, I realise I've been talking for quite a while, and I haven't sort of taken on board any of the questions. I think probably now is probably a good opportunity.
Raj, can I ask your support on 3 or 4 questions that we've been asked? It's for Linda.
Yeah, hi, Belinda. Yeah, sure.
Yeah, so one question that Raj is asking is, are we currently promoting NHS Mail to set up the service?
That's a really good question, Raj. What we're doing at the moment, because I'm not certain to be able to get the funding in place for the EMIS or Ardent or any other IT solution. So we are at present promoting the use of NHS email to surgeries as a startup mechanism, and then saying, look, we may want to evolve this at a later stage, so please be prepared if we want to evolve this using other mechanisms.
So following on from that question, Enrico has asked a question.
Sure.
How to claim the NHS mail referral on...
Okay, so I was discussing this today with my peers and also other colleagues. So the way it works, they should have the surgery will have a SNOMED code, which will, when they send that off, which will trigger a message to NHS BSA. So when you go to manage your service, there will be, when you click onto GP-CPCS, it will be differentiated into GP and NHS 111 emergency supply or a minor ailment. So it'll be differentiated at that level.
And one last question is that, is there an expectation that that we give feedback as community pharmacies, we give feedback to the GP on all referrals, or only selected referrals when the GP wants feedback?
So far, the dialogue that we've had with all clinical directors is that they'd like referral back for all patients, because what they're saying is that it kind of completes the loop. So when they see the patient next time, and they can then see, oh, this patient has been seen by a community pharmacist, and this was the outcome, I need to now do something different to what the community pharmacist has done. So you can imagine if somebody goes in with a rash and we've used hydrocortisone and it hasn't worked, and then they've gone back to the GP and they say, oh yeah, we have some hydrocortisone, and the patient's going to say, oh, I've already used that. So yes, feedback is required. It may not be always action. They will probably just feed it into the system, into the patient records. So the next time they see the patient, it will be available for them to see and then take from there.
And we're getting asked a couple of questions on, are we going to be using Sonar or Farm Outcomes?
Right, again, I don't know is the answer to that, if I'm very honest with you. What I'm hoping is that if we have the EMIS solution, which is an all-encompassing solution, and they do use Farmer Outcomes. Sonar, as I said, I'm not sure what Sonar's offer is, because it hasn't really detailed what happens between the surgery and the community pharmacy.
And there's a question here referring to Farmer Alarm, and would that be used, would we be using that even if we're using Sonar platform?
At the moment, I don't know. I mean, at the moment, within Southeast London, the CCG pays for AccuRx. So that's where we are. So it may be AccuRx. AccuRx is just a means of sending a template to the community pharmacy using NHS.
What?
PBS America.
Okay.
Sorry, I'm watching this. Hold on.
India program.
Okay, I'm going to mute everyone. So I do see a couple of hands up. I think Bipin was first and then Enrico. You'll have to unmute yourself before you.
Hi, everyone. Just the question about feedback was from me. Okay, I take the point they want feedback on everything. That's fine. But I think the IT solution that we should be looking at should be one where we don't need to populate everything. We can just answer back and it goes back into their system. We shouldn't have to create a document or something and then send it, because it needs to be just as the GPs want an easy solution, it needs to be easy our end as well to feedback as and when we need to do it. So, you know, if we go for Sonar or pharma outcomes, I think it needs to be the same sort of format. And just, I think the question about whether we're going to use Sonar or not, I think obviously when, if I'm correct, the minor ailments, the CPCS platform is not going to be paid for by NHS England soon. Is that right, Raj?
Yeah.
Yeah. So when that stops, then the contractors will have to pay for the platform themselves. So I think that they're probably not saying it openly, but they're probably banking on that. We'll have to pay for something for the minor ailments ourselves, and they're hoping that the solution we use will have the other part as an element to it. That's just my own personal view.
Thanks, Vipin. Enrico?
Yes, so regarding always to claim the payment, yes, for the referral, I saw in MYS the differentiation between 111 referral and the GP-CPCS, but I'm unable to add it because there is no way that you can add it. And even the system tell you, if you got any discrepancy, contact Sonar or pharmacy outcome. So I don't know how to add it.
You're not able to add it. You're only able to confirm it, or if in your case you're not able to amend it, you have to contact them to say, you know, I did 3 and it's only coming up as 2.
Yes, but because I'm receiving the referral through the NHS email, how can I? Who do I have to call to add it to the system? This one I can't understand.
Okay. Can I talk to you tomorrow about that, and we'll figure
Yes.
out a way of how we can make sure that that's amended for you. Okay. I'll
Thank
give you a
Thank
call
you.
tomorrow morning, Enrico. Okay.
Thank you so much. Thank you.
Yeah, Raj, just one last question for me. There's a question around the GP surgery sending the GP-CPCS via email, and how will that generate a SNOMED code? And will we be relying on the GP surgery to input this code? And
So,
will that introduce risk?
yeah, that's from Dina. Thanks, Dina. When I was speaking to the clinical director today, he was saying that there is a code for referring to community pharmacy. That I want to embed that into the referral form mechanism as it gives out, so we don't have any problems with when they actually refer. So he was saying when they refer by email, that code is automatically added onto it. So I'm going to need to have a chat with some of the community pharmacists. I know Bavin's on here. I need to have a chat with some of those guys who actually work in GP surgeries to find out how that's done. So that's why, as I said to Enrico, I need to have a chat with one of the colleagues who works in GP surgeries. Okay. Right. Is there any more questions or observations, or any other questions that you need about GP-CPCS? It is a very, very important service. I mean, I can't stress enough how NHS England and I are looking at this as a way of giving more services to community pharmacy. And I'm sure we have many challenges on the horizon for us through hub and spoke supervision, and how we actually ensure that we retain that link between the patient and the pharmacist in the pharmacy. So that's where I really want to be at. And I see this as a mechanism of strengthening that relationship. So,
Raj,
yeah.
just a comment. I think the key thing here for this success is, I think you are correctly pointed out, is a good IT system. And as Bipin said, it has to be easy at both ends and not just at one end. Accurex, one of the things is because something that we use in Lincoln, it's that it immediately goes into the patient's record in the GP surgery. So if you just say, seeing the patient, give an advice, it literally just goes into that system. It's a question of if funding can be made available to have pharmacy attached to the Accurex. Yeah.
Okay.
So we I think need to dialogue. PCNs do have money to develop integration fund of some sort. Maybe this is where we need to identify this monies, and this is one way of integrating pharmacy with GPs. So let's look at that, hopefully, because if we can standardize this referral pathway and IT system, then I can see a success. If you're going to go halfway Sona, halfway Accurex, halfway Pharma Outcomes, it's not going to work. We have patient access as well. If majority, I think maybe might be a good idea to see which pharmacies as a base, where we stand. Do pharmacies have patient access? Do they have Accurex already set up? That might be a good starting base. So maybe we need to do a Google survey to begin with and see where we are.
What we'll do is we'll take this up next week in our LPC meeting. You may need to sort of give me a bit more detail.
Okay.
Okay. I've got a question here from Raj Patel. Is this currently a financially safe service for community pharmacy? What do you mean by that, Raj? I mean, because it's within the fund.
Well, what it is, there's a lot of say IT and a lot of other things, communications pathways are not being settled yet.
Yeah.
So where claiming and things are becoming complicated, that's what I mean, that whether is it financially safe at the moment, it will, I'm thinking that it will become so in the next the foreseeable future, but we are, the ducks are not lined up yet.
No, you're absolutely right. So when I challenged NHS England and said to them, look, you had a blueprint in London where we developed the flu service, where everything we had it set in place, and then we went out and told everybody about it. We had figured out the training, the SLA, the IT, everything was done before we actually went out. And their response was, well, our principle of commissioning services for community farms is not to have everything ready, but just to see what works, and then almost sort of evolve and develop the service as it's taken out in the market. So I quite agree with what you're saying, and that's why probably we need to work at a small. That's why we're working at a very small level with individual surgeries at a time, rather than going across the whole of the system. So we'll see a lot of chinks which need to be ironed out before we can get this service up and running. And I think that's why we need to work with community pharmacy friendly GPs. I've got another question from Shalinda saying, can we still get text notifications as we do it currently? I think that will not happen because those cost money, and I don't think that will be happening. Okay.
There's an operational question about workload. When this gets established, how will we manage the workload from referrals? Will it go out of control?
So you'll be getting income if it goes out of control. So, you know, you've got to be able to look at your pharmacy team right now and see how you manage that team. You've got to look at it and say, where am I best suited to be at? Are you best suited to be at producing labels or dispensing, or are you best suited to be dealing with patients? Because I think the drive by NHS England is to push pharmacists to dealing with patients, and the mechanics of actually dispensing to be left to the pharmacy team within your pharmacy. Was there any other questions, Belinda?
No, I think you've got the majority of them. I think there's lots of debate about sonar and pharma outcomes and IT solutions.
Yeah.
General debate of questions, and clearly there's some operational questions as well. And I personally, having read the Pharmacy London document, I think most of them will get answered by going through that, and there'll be some ongoing ones that IT solutions that we worked out over time, I think.
Yeah. Okay. Girish is asking, is there a deadline on the referral? I'm not sure what you mean, but you have to be able to respond to the referral within 24 hours, Girish. So if a referral is sent out, say late Friday evening, then your locum, or if you're there on Saturday morning, has to be picked up by them. So you can't kind of leave it hanging, because we're still getting quite a few with the NHS 111 service which aren't opened up or dealt with. So I do need to see that response being done. So, you know, if community pharmacy responds to these consultations, that will give confidence to your GP to say, you know what, I can send these out to community pharmacy, they will deal with this. So it's really important. From a patient point of view, I'm not sure what you mean by that, Girish. Are you saying, does a patient have to contact us or we contact them? Okay, so what you're saying is, at the moment for NHS 111, I mean, I know if you send Sonar an email, he does open up, and I know it's not universal, but I have been pushing him on that to say, you know what, you do have to allow access to locums anywhere that they want to work. What about item fees? 7-day chemists item fees. So there's a consultation fee of £14. So that's just a consultation. But if any OTC sale, then that's up to you how you actually treat that particular condition. Yeah, I quite agree with you, Suk, about having to make it easier access for everybody. And that's what I think the patient access solution does. So it's a one solution that frees up everybody to be able to access. Okay, so there is a lot of still a lot of debate going on. I very much thank everybody for coming today. Please, I'm quite happy to carry on the discussion online. You have my email. Then please engage with us. Don't sit in isolation. Valinda is also there. The PCN leads are also there. I think you will find as we move forward, the PCNs come into their own, but there's another element that has been emerging, which is called the local care network, which we will also have to engage with. So the PCN is all about general practice. The local care network is all about the council and other providers working together to provide services. So I think very shortly, I've got a meeting with the chair of the South East London CCG to just get some clarification on that. Where can we target our limited resources with the care networks? I also just want to say that I will be asking my PCN leads to talk with all contractors regarding electronic repeat dispensing. We have been commissioned by South East London CCG to improve the uptake of ERD, and we hope to do that working through our PCN leads. Okay, I'm going to give you 3 minutes if anybody's got any questions or observations or discussion points. Just want to point out again that on Monday evening at 8 o'clock, we have our LPC committee meeting. So that's the full meeting of the committee membership. And again, you're more than welcome to join BBG on Monday or LSL on Thursday. It's via Zoom. The more people that we have attending, the better it is. I want to make sure that both LPCs are open, transparent and accountable to our contractors. It is an open culture that we have within the LPCs to ensure that, you know, contractors are able to see what work that we do on their behalf, and they're able to understand some of the sort of background to some of the decision-making process. So I would welcome all of you to attend that. Other than that, I think I'm going to close the meeting with a couple of minutes to spare. So I've given you 2 minutes to yourself, so use it wisely. Good evening, everyone, and I hope to see you very shortly. Thank you.
Good night, everyone.
Good night, Girish.
Good night.
Thanks, Raj.
Thank you. Thanks, Belinda. Really helpful. Really appreciate you managing the chat box for me.
Thank you, Raj.
It's my pleasure, everyone.
Yeah, thanks, Raj.
Thank you, Raj. Please,
Thanks.
can we have the recording of tonight?
Sorry?
Can we have the recordings of tonight?
Yes, I'm going to be putting it on a YouTube channel. I can't be too much to download by an email, so I'll put it on a YouTube channel so you can have a look at it.
Thank you.
Okay.
Thank you, John. Nice to see you.
Thank you.
Thanks, then. Bye.
Bye, Elizabeth.
Thank you. Bye.
Bye. Thanks, Raj. See you later.